This morning I have the incredible pleasure of introducing our Grand Round speaker. For those of you, since we had kind of the review today, she was a medical student from New York Med, so I think she may have actually begun the process of the pipeline. She did her residency here, and just so that everyone is aware that if you take a look and you see where's Dr. Bass, and we also bring out all the big hitters as well, like Dr. Goldfrank and Dr. Hoffman and so many of the other attendings and residents who have been here. But you can only do it if you have somebody like Tsion here to give grand rounds. She, after completing residency, she went on to do her fellowship at Columbia, and to kind of list all the accolades, I was told by her specifically that the only thing I'm really allowed to say is she was my resident, and then get off the stage. But that really wouldn't be doing her justice. So I just wanted to, and you have this in your grand rounds kind of communication. But Tsion right now is the chair of the academic chair of emergency medicine at Africa Health Sciences University at King Faisal Hospital in Rwanda. She's an adjunct associate professor here at NYU and a senior advisor overseeing emergency medical services at the Ministry of Health in Rwanda. That's only just the beginning of all of the accolades and all of the things that she's actually accomplished around the world. And while you can read it all here, I just want you to know how incredibly proud we are of Tsion being one of our alumni. But more importantly, she's a wonderful friend and a wonderful colleague. And it gives me great pleasure to give the stage over to Tsion.
I am feeling nervous and anxious being at an institution that has taught back, home at an institution, and among, yes, there's so many people here that have really shaped my career, and as I'm talking, I'm seeing more faces, so nice to see you. And it's just, people that knew me before I knew how to doctor. Like, I did not know how to read an EKG, and to speak in front of this many people and all my teachers is such a pleasure and an honor, very humbling and also nerve-wracking. So as I was just talking to my husband on the way here, he was like, I see you talk in so many places, I don't know why you're nervous about this. So if I talk a little bit loud or like a little bit, giddy, please excuse me. But it is so, just so overwhelming to see this many faces. I just did a walkthrough at Bellevue before I came in with Tim Green, who was my senior resident when I was he's loved by this. He's overnight, so I was like, please go home and sleep. So, and then, yes, I have some pictures. So part of coming home is, think about like after college when you go back to your parents' home, there's like some pictures that come up, right? So I have some pictures. And maybe what you're not used to, my talk today is going to be a lot of storytelling. I think there's some, it's just another level when you're really telling a story and attaching it with some of the evidence that comes with that. So I know it might be a little bit different. It's not something that I was used to as a medical student, as a resident. It really taught me as when I was doing my MPH. A lot of the things stuck. We do it, right? We're talking to patients, telling their stories all the time. But when it comes to the teaching, that kind of gets lost. So I'll be doing that, and I'll be trying to watch my time. If you can't get the notes, it's okay. We'll manage. And then thank you, Manko, for that kind introduction. And people have told me in the past, like, how do you really say your name? Yes, I've told everybody Tsion. People are like, we've heard it. Some people say it very differently, so it's okay. The Ethiopian saying is Tsion, and I've been always, getting tired of correcting people. It seems the same thing. So it's like, seems like reintroducing to all of you guys. So it's okay. I've been called Tsion all my life by the same translation from the Bible, so that's completely fine. I am trying to change my slides, so I'm already feeling old coming back, and a lot of technology that I'm not sure about. And then I also see some of my co-residents who are not in New York who joined online. I hope it's okay, but they really wanted to come and be part of this. So I recognize some faces and names on Zoom, so thank you guys for coming. Great. Okay, so let's get to this picture. So who was here doing Superstorm Sandy? Yes, right. So, this is when, okay. So, part of coming home, like I've said, is really telling the stories and walking down the memory lane. Right in the middle is Joe Novick. Back when I was a resident, he had also spent some time in Rwanda, as some of you guys might recall. And the pictures on the left and on the right are during the Superstorm Sandy. And then I think you see some faces that were familiar. We had no power. That's why the pictures were dark. Oh, and then I know it might be very difficult to imagine for the residents, but when Sandy hit New York City, within a matter of a week, I don't remember, the entire Bellevue and Tisch Hospital was empty. Like, it was empty for a duration of 2-3 months. And we were like, little refugees going to different hospitals. I don't know where you were, Amy, but I had to go to Beth Israel. Some people had to go to Kings County. So this is the kind of stuff that, I'm going to be alluding to climate change, but as an emergency physician, and actually the entire institution had to go somewhere, spend time, and then the emergency department was the first place to reopen. And I'm going to have some embarrassing pictures of my, people that were around. So, of course, parts of, as I reflect back on my journey as an emergency physician in global emergency medicine, I attribute to most of my education of what happened here at Bellevue and at Tisch, but also it's not only from the faculty and the senior residents, but it was a whole community, right? When you were sick, it was your co-residents that were there besides you. This is me at Tisch. Please do not go to the Red Lobster at Times Square. And it was like the resident, I was feeling horrible, and then it was like my entire co-residents coming to make me feel better. I don't know if that place is still open, but please do not go when they have the all-you-can-eat lobster on Tuesdays. And then it was also part of the payroll, the team of nurses, some people that I actually saw today from many years ago. So, for those of you guys who don't know, when Amy and I graduated, it was exactly 10 years ago. We've been trying to have our 10-year reunion with our co-resident. It kind of happened yesterday with just the 4 of us. So this was about 10 years ago, and we started in 2011. And of course, there's teachers in this room who some of them, are in this picture. I could not put everybody, of course, on my slides, and I was able to acquire, but as you can see, Dr. Goldfrank, Suzy Vassallo, Uche Blockstuck, Silas, my goodness, why am I blanking on Dan Egan, and also Ambrose. I know that he's back, but Ambrose was also our senior resident. So these are the people that really shaped the whole journey. And of course, embarrassing pictures with everybody from the team. Tim Green is here, Salil, with excellent faculty and also senior residents that we had here. And Salil stayed here as a faculty also for a few years as a nocturnist. So really, of course, I could not show everybody here, but really most of what I'm going to talk about and how my career had been shaped is really because of what the exposure. Now I have residents in Rwanda, and really what I talk about, I think they know about each specific, back in my days, it's like that's what we're saying now. And then when I was a resident, there was this attending or consultant, as they say, and I'll really tell the story. So I think they know most of my attendings by name. They're like, I know. So that's how my residents. And then, I have had some pictures here and there. One of the things that we really appreciated as a fourth year is this discussion that was mostly on non-medical stuff with Dr. Goldfrank. And I was just talking to him outside for 30 minutes, and of course, a discussion and a talk with him, just like very inspiring and really telling me about his experience when they were building emergency medicine, which is kind of the challenge that I also am seeing on the other side of the world. And I was just kidding, saying for that 30 minutes I spent with him, I felt like I needed to get the CME credits because I learned a lot. And there's been some full circle moments. In the past year and a half, I've been in Rwanda. I did not know this, but Jason and Lenny were been organized separately, non-NYU. They've been doing a separate medical mission work. And he just texted me one day, hey, I heard you're moving to Rwanda to do some work. He's like, I've been coming there since last year for a medical mission. And then I was like, okay, well, I'm going to volunteer to start teaching my residents when you come. And they did, the whole team. And for people that don't know, Ryan and Cameron were my residents at Columbia. So this was having the entire crew back in Rwanda, just happened by chance, and they were part of the teaching for the residency. So I should tell you guys that we started a residency program in Rwanda, the second emergency medicine residency, which was what I'm leading. And they had the opportunity. So when they came, there was only 9 residents, and now we've grown to 23. And hopefully in the next, 2 more years, we'll graduate. And there are some medical students from here. He's on medicine rotation, so he couldn't come. But also Jake spent 3 months. This was all taken in Rwanda. Datambenga, he leads the Health Institute for Equity here at NYU. He also happened to be there. So just Rwanda has been a place that attracts so many people, and also the NYU connection continues. And there's been so many, of course, full circle moments, but I'm a firm believer in the quote, to whom much is given, much is expected. And it's really building on what I've built, what I've learned here, and to be able to share that to the rest of the world has been, a big honor for me. So I think done with the embarrassing pictures. That were not too embarrassing, right? I decided to, because when I asked my co-residents and they were showing all these pictures from the bar, I'm like, people are going to think we did residency inside the bar. I just showed all these pictures from the Robin. That's how we actually coped during Super Sandy storm, like the Sandy storm, and we'll just go out after a shift and talk about our experiences among the different hospitals that we were in, and we're like at the end just to say we were so glad to be at NYU in Bellevue after having seen many of the residency programs also in the city. There were great experiences, but we also appreciated the resources and the support that we had here. So for the next 40 minutes or so, this is what I'm going to talk about. Of course, I can't really cover what global health is, what global emergency medicine is, and the 40 minutes I'll be with you guys. And I've actually given very similar ground round here 4 years ago, but it was virtually through Zoom. So this is a great welcome to be here in person. So really talking about the opportunities and challenges in global emergency care. And recently, I was caught in the middle of a Marburg outbreak, and Celine did sent a wonderful email. There was a story on NPR about my personal story, but really the effort is a collective effort. I probably had 0.0001% contribution to the entire response, but it was it's one of the stories being told as the most successful outbreak response that the world has seen. So I'll share that, and then many of what I'm going to be talking about is through a personal journey, and I struggle between telling the stories and also don't want to also make it all about me, but I think who else can tell the story better than yourself? So I'll be sharing some of that and really try to minimize. Sometimes it feels like a bit of self-promotion, but that's just maybe me. So when we talk about, you talk to strangers, like, oh, I do global health. Also, like, people who are my colleagues, and people think that I'm doing those things. And yes, I did those things maybe for a huge part of my fellowship. And to do global health, you don't have to do global emergency care. You don't have to do a fellowship. But I decided to do it because I really wanted to get an MPH and understand at a population health level. And I'm glad that I did that. And I've had multiple exposures because of that. So the reality of my work right now is this. I'm not doing the fun stuff in the field. I am caught in boardrooms. I am caught between piles of paper. I'm doing a lot of work in the airport lounge and many other places. But over time, as the story kind of changed, yes, it's great to be in the field and to doing those things, but there's always things that, what are the bigger picture? What is the sustainability of things? Yes, medical mission work is great, but how do we sustain it and make it focus on capacity building? And as you talk about, we're all emergency physicians. We advocate for patients the second they walk in. Whether you work in the hospital or whether you work in urgent care, there's a lot of advocacy that we do, and that's just what we do as physicians. So for me, my started really working in the field, and I'm going to talk about a little bit more about that. But then over time, I just felt like the advocacy needs to be on a higher level, on a global health level. And we don't get that as much as part of the residency. And I know residency, you just have to get through it. But I think what you develop over your residency skills is most of what I've learned, I've been able to translate into the global health, the population health, and the advocacy that I do at a higher level. So again, the journey. I was born in Ethiopia at a hospital called Black Lion or Tukur Ambassa. Tim Green actually went and worked there for a month. He said he performed like several pericardiocentesis that he's ever done in his life. And when I was a resident, and I'm going to just tie it to really part of my NYU residency, ultrasound was a big thing. We had a faculty, there was an entire program that was being developed. And emergency medicine in Ethiopia was developing at the time. And I had actually part of my decision to go into emergency medicine was like, how can I better contribute? And I remember walking into my residency interview and being interviewed by Dr. Goldfrank and by Dr. Manku, what is it that you want to do? How do we, and the same questions were happening in the hallway earlier. So part of it was like, I really want to be part of also global emergency medicine development in Ethiopia. And of course, where else to train better than here? Because Bellevue was really the experience and the lessons on establishing an emergency medicine residency really exists here. So, at the time, of course, it was not me as a senior resident teaching them all the science. Yes, I could, but ultrasound was a novel thing, and they had a small machine that we were doing. And I am very proud to say that many people that are here as the students and as residents, they are now the leaders in many institutions, not only in Ethiopia, but across Africa. And some of them are my colleagues from Rwanda. So I'm the grandfather, like 2 generations of emergency physicians. So just that pop up like, oh yeah, we remember when you came and gave a talk. So for almost a year, I worked with the individual here. Is that projecting? His name is Dr. Johannes in Rwanda. And I used to say, I can't take credit for him because he wasn't my resident. And then he shared this picture. He's like, look, there's this picture. He was a student, a 4th-year medical student. Actually, sorry, a 6th year, because it's a 6th-year senior medical student doing his emergency medicine rotation. Over time, part of also the experience here, there was CIR, does it still exist? The CIU. So they had an opportunity for medical residents as a 3rd and 4th year to go to Haiti. They will pay, you will apply with a scholarship. And my colleague, Dr. Farshtasani, who's also on the line, also went there, and we spent, I think, about 2-3 weeks. It's a hospital that was set up both after the earthquake in Haiti. And, my ortho rotation, I remember trying to put a traction pin, and I remember saying, I'll never have to do this ever. Why am I learning how to do this? But I learned through it. And I know Dr. Testa, right? And his father he was the chair of orthopedics at the time. He was really teaching us, about many things, but of course, really to take pride in my residency training here at Bellevue. And, so we put the traction pin, had all the ortho bros teaching me how to do it. When I went to Haiti, we can't transfer this patient now. There's no bed. And I'm first and I used to do day and night shifts. I'm like, so she was sleeping. I'm like, how am I going to put this traction pin? And I think I called one of the ortho residents there, and then the local tech was helping me. He's like, you just have to put it, I'll do the rest of it. Because this lady had motorcycle accident with a femur fracture, and she was bleeding into her thigh. So we don't have blood to give her right now. Oh, what's happening here? I think I got tired of my story. While Nico fixes that. And really part of the things I'll never need to know, but I learned it. And then eventually I was able to really put that into practice. And part of the experience also really the opportunity came because I was here as a resident. I promise I didn't touch anything. No. Okay. It's like a 4-people operation. Yeah. I'll drink water. As they do that, I'll continue to talk because I don't want to take too much. I want to make sure I finish on time. And the next slide is just going to show a picture from Ghana. Sorry, I don't think she's in this room. I think all the residents know her, right? Sorry. And she was in Ghana at the time working on helping and developing an emergency medicine program. So part of our 3rd and 4th year opportunity was to go to Ghana, and I spent some time with her. And really, I was just also mentioning this to Dr. Goldfrank outside, really some of the challenges that she faced, the battles of establishing a new program. And it's one of the things that I take on and really build on the experiences, really just the role modeling, how she used to do it with various, stakeholders, different departments. really starting, we don't know how good you have it to be in a place that has established emergency medicines for, 5 or 6 years ago. This is kind of like the daily struggles that we witness on the other side of the world. And as part of fellowship, we had the opportunity to go into different parts of humanitarian response work. And, fellowship gave me an opportunity because within it's like emergency medicine, but there's also, after global health, there are different things that you can do. So if you talk to anybody that does global emergency care, it's either humanitarian response, on health system strengthening, like what I'm doing really focused on, and other people really focus on education and training, things also that I'm working on. So after Ghana, so this is the one of the hospitals in Ghana. Initially, there was only one residency program that was started through a collaboration with the University of Michigan. Now there's a second program in Accra, Ghana, what Sari had actually worked on developing. And I'm not sure if this video will play, but I never thought I would do this in my life, but there was an opportunity to be in the middle of a war zone in Mosul, Iraq, 2016-17, backed by the U.S. coalition force. And I would have to say in the month I was there, I've seen the most atrocious injuries, like bullets through brains of children. And it was something that I was never prepared for to see. And I don't think we could have had, I don't think I could have had any sort of, and this was happening at this trauma stabilization points, which are the treatment centers that they had for injuries. So this war involved many civilians. And along with that, it was under captivity, under ISIS. So the way it would happen is that they would, the Iraqi forces, backed by the U.S. forces, would go release a town. So they will get us, the people that could walk. It was a triaging system. If you can walk, please come to this bus. So they will take the people on the bus. The people that can't walk, then they'll do the triaging. The ones with an acute injury, they'll send to us. So these trauma stabilization points are not hospital. We just go there, find a house that is functional enough for us to set up a clinic. So we were really moving with the forces because you really have to, not the whole golden hour, but you have to give some sort of immediate care. So we also did a second round of triage. Okay, this patient can wait 1 hour. They can be transported through ambulance. The people that needed to be, that needed immediate surgery will, start transfusing, giving TXA, and then helicopter them out to Baghdad. So really, one of the things, this is through an organization called New York Medics that's based here in New York, and it's run by medics, all pre-hospital providers, and then we had, they brought in the physician as volunteers. And one of the things I remember here when I was a resident, we learned about debriefing and simulation. And after just a terrible day, you don't know when the operation is happening. All of a sudden you hear like there are sirens coming. Of course, it's like high-level military action, so they won't tell you, like, can you please tell us so we can prepare? Like, just be prepared, right? So then you'll free up beds, prepare. We at the time was like one physician, that was me, and then there was another resident. So we'll just divide it because you'll get like the rush of patients of 40, 50, like who's stable, who's red, who's green. And then after you stabilize them, it's just like, we can really translate what we learned in our residency, the debriefing, and we'll come together. Because not only have you seen the most atrocious injuries, but also just working with a team of, I didn't have any nurses, many were medics. So it was a bit difficult to really, have a Bellevue level or NYU or Columbia level of medical care, but also working in a very stressful situation. And I was there for 4 weeks and really learning implementing what I learned here within the, the residency to implement that and put it there was really gratifying and the greatest honor for me. So at some point, yes, I did the field work, and at some point, it was getting to a level of where I really need to advocate at a higher level. Yes, there's hospital, university level issues, but many of the issues needed to be fixed before they came to the hospital, right? Yes, prevention works, when it works. If it was for prevention, I think half of us would not be here in this room, right? So a lot of, what happens within the African continent, there's been a lot of especially when it comes to global health, there's been really an investment on vaccines and prevention. But we see a lot in emergency medicine when that fails. whether it's, road traffic injuries, it's because the system has failed. And this is one of the things that we received during our trainings, like, the failure of the system come to our emergency department. So I had the opportunity to do that as part of my fellowship and got exposure to that. And my focus has been really on health policy, and most of it has been like working with the WHO and also with colleagues from the ministries of health in Ethiopia. And I want to show this 5-minute video. And who has seen before you play it, who has seen the documentary 24/7, 365? Amy, I know you have. Okay. So that's a good thing for many of our residents. I really, really encourage all of you guys to watch it. It really tells you about the documentary, it tells you about really how emergency medicine was developed here. And this is a trailer. And I'll play it because many of you guys haven't seen it. And I'm sorry for the people who have been to my prior presentation. I play this for my recruitment. I play this for many other videos when I have to talk about emergency medicine. And you'll see some familiar faces in there. If it doesn't play, it's available online. Okay. Can you guys hear it?
These were all family practice physicians.
You can hear it?
Certain number of shifts a month in the ER.
Rana, can you hear it?
The way ERs are being run is very, very
The early people were clearly mavericks.
These were all family practice physicians who worked a certain number of shifts a month in the ER. Jim Mills realized the way ERs were being run was very, very bad.
The early people were clearly mavericks, and some of them were just crazy. They were really outside of the establishment medicine.
It was the Wild West. Everything that happened in the emergency department. We had a police station there. The sheriff was always there. It was a very exciting place.
I had no idea I was making history. I was just living my life. And yet, we were changing the practice of medicine in a very significant way.
There is something that's so different about what we do. We're the only clinical specialty available 24/7.
Whose hospital is it? What is healthcare about? What does it really mean? What are we here to do? That's what emergency medicine answers.
The mandate, whoever, wherever, whenever, changed the course of my life.
One place where you can go and everybody gets treated the same. The emergency department is a 24-hour, 365-a-day business. You have to be prepared for everything.
It was an awesome thing to watch the development of this over the last 40 years.
If you don't take a look at where you've been, you can't really figure out where you're going.
I think we learned damn well.
So if you haven't, too much echo. Okay. So if you haven't seen that, please, I really encourage you. I play this video to many people. The ministers that I've worked with have seen it, and I make my residents watch it. So I think it's really good. If you don't know, like what they say at the end, if you don't know where you've come from, you don't know where you're going. So I think it also appreciates some of the challenges that you're facing. Imagine, people that were developing emergency medicine in this continent, like 4 or 5 decades ago, the challenges that they face, and really standing on their shoulders to continue to do that. And I use this as my advocacy, like when I'm showing this video, when people are not understanding emergency medicine, besides explaining it, I also show this. I will do it for my medical school recruitment and many of the outreach things that we do. So, in the video, they really talk about advocacy, like, the emergency department is a 24/7, 360 system. And I think I mentioned this earlier, really, we advocate for patients the first day they walk in. And at the center of what we do is really advocating for the patient. So taking it to the global emergency level, part of my advocacy, as you guys know, I know the great saves earlier, there was a malaria case that I was mentioning, but that happens. Yes, TB, HIV, malaria are the biggest challenge of the global south, but injury is also killing more people than TB, HIV, malaria combined. But a lot of the funding, whether it's from the UN or from nonprofit organizations, when it comes to the global south, is really more focused on HIV, AIDS, TB, and malaria. And part of the advocacy tool is, like, of course, showing the numbers and also showing actually the gaps, right? There's 36%. Yes, I'm not saying it's not important, and that's what has actually led to the reduction of HIV in the global south. But we also need to invest in really what matters. And part of the advocacy is that when you invest in emergency care systems, yes, it will address acute complications of HIV, TB, malaria, but it will also address your injury issues and the complications that comes with injury in general. And we haven't been able to find, of course, the recent data on this, but from 2017, it shows you the huge gaps that come with that. For every daily that's associated with HIV, there's $4 that's been contributed to that. For malaria, around 10. TB, now maternal and child health. And of course, you see really now the change of the this global health financing move into maternal and child health, which is great because it's also an opportunity to help you to help on the emergency, on the healthcare system in general. But there's a huge loss, and you can see this from the numbers that traffic injuries are the first cause of death, are the number one cause of death among children aged 5 to 14, and also age 15 to 29. But still, the amount of money that goes into that is much less compared to the infectious disease. So when people think about global health, they're really focused on infectious disease, but we need to have a narrative change on that. And, for per year, it's about 1.35 million dead. How many people did COVID kill in the first 8 months? Between May, or I guess March of 2020 to December, about 1.8 million. Yes, again, infectious disease makes the news, but this is the kind of stuff that never makes the news. And for the duration that we've been here for 1 hour, maybe you'll tell me in the next 2 slides. So per every minute, that will take me between the next 2 slides. I'll tell you what the numbers are, but I'll get to the next 2 slides. So how do you advocate for these things at a higher level? 7 blocks, because we're at Tish, right? So on 42nd, 10 blocks up, there's a UN, right? And I did not know this, like the amount of health-related discussions that actually happen at the UN when I was here training. And of course, this is not trying to fault anybody, but I think part of it is that the advocacy level at a global level, of course, is not something that we're expected to learn as part of residency, but over the years, I've come here for the General Assembly and various events, and much of the discussion, yes, it could be about politics, it could be about peace and security, but the high-level agenda on health happens every year, and that high-level agenda discussion on health is picked by the WHO and by the member state, meaning the countries that actually are part of the WHO. And the WHO has an executive board and what they also call the World Health Assembly that actually identified the high-level discussions or also shape global health financing. So we took our advocacy. Yes, we can really focus on training emergency medicine in the global south, but But if we can't advocate and lay a good ground foundation, it's not going to work. So it's a full lecture on this, but really, okay, going back to that, so within 1 minute, about 2.5 people die. And for the duration here that we're together for 1 hour, around 156 people die globally because of injuries. And I know people are looking at me like, wow, like, you know, your face tells it all. And many people don't know about this. But again, a lot of the funding goes to infections. So part of the advocacy is putting emergency care systems within what they call the Sustainable Development Goals. They are a list of goals and targets that were developed by 2015. Now we're almost more than halfway there to 2030. And HELD plays as Sustainable Development Goals is 3 is focused on HELD, and it has different targets and such, over 169 targets. But really investing in emergency critical care and operative care is the model that the WHO uses, can help meet the SDG targets. And all the countries, whether it's at the UN meeting or the WHO assembly, they are supposed to give updates on the progress. So really advocating and talking to the health ministers, the decision makers, the policy makers to say, invest in emergency care system, and all the most of the problems that you have could help be alleviated. And it doesn't help, you know, when you go into these rooms and talk about, this is your problem, this is your problem, this is your problem. It doesn't. They know it. It's really going with solutions. And that's how you're able to win some of the discussions and be part of the table who's making the decision. So Dr. Tedros, you know, when he first tweeted, of course, this was like, you know, about 7 years ago. And like, yes, the Director General of WHO is tweeting about emergency care system. We're getting there. And we also drafted a resolution when I was working at the Ministry of Health in Ethiopia, drafting a resolution that actually is focused on emergency care systems. And we were able to get that passed at WHA in 2019. And that has been a guiding principle for many of the countries to implement. And unfortunately, of course, the pandemic happened, and there was a new resolution that really put emergency care system within the pandemic response, and that came out in 2023, and also Ethiopia led that. So, of course, we had the opportunity to work with many people from different parts of the world to really help advocate for us for WHA 2019. That helped, and if you just Google it for anybody who's interested, it's available, and it's a guiding principle and a sort of a non-binding document that helps countries lead how they implement some of the tasks that they've been asked to do so, and the WHO actually supports this sort of and helping achieve the resolution. And then, of course, part of it is like, yes, when we talk about road traffic injuries, you can't work in silos. You have to work with ministries of transport. And when I say ministries, I know in the US and the UK and most of the European countries, they're called ministries, but here it would be like the secretary or the agency or government agency. So I've been in meetings with, police officers, because when you talk about road traffic injuries, it's really about the prevention part, and also ensuring that people are arriving to the hospitals on time. And part of the advocacy also involved, like when I was here resident training, and I hope I don't offend anybody, but I used to be one of those people, I'm like, I don't know if I can sit through another journal club because I really have no idea what they're talking about, and how I really could translate that into our daily practice. And then, of course, there are excellent and smart people in the room who will help us get that. But I never thought I'll be a researcher, and one of the hats that I wear is a research. And I know yesterday you guys had an amazing lecture by Dr. Radhika on implementation science and global health. And implementation science is one of the most attractive branch of research for global emergency medicine. So I also partake in that. And most of my work, where I brought residents from different places across the world, is really to work on the research. And also the medical student like Jake, he spent 3 months there and has been really helping with the research, and he's planning to come back next year as part of his 4th year we have here. Yes, he loved it so much that he's going to not graduate in 3 years, but in 4 years to be part of the research aspect of things. So that will be an entire 1-hour lecture, but I have to get through this in the next few minutes and talk about Marburg in the 15 minutes I have left. But I think hopefully, through my personal story, I've kind of talked about what are the different things that you can do in global emergency medicine for the residents and also for the faculty and the fellows, ways that you can contribute, and there are ways. But of course, there are challenges that we anticipate and that we're actually seeing. The effects of climate change, right? I mean, Sandy storm here happened, right? As we speak, now in Jamaica. And I think as an integral part of that, emergency care system and emergency physicians could actually play a huge role in that. Infectious disease. I mean, in the past 5 years, I mean, you guys as residents and medical students, you've lived through COVID, Mpox, right? And then I'm pretty sure if you ask people who graduated 3-4 decades ago, they didn't, I don't want to call my age, but they didn't witness that many frequent outbreaks. And for me, I was in the middle of the Marburg outbreak last year. So for me, in the past 5 years, I had to deal with 3 different outbreaks that, one just completely stopped the world, right? And then the others, it shook, Europe, US, Sub-Saharan Africa. But these are things that are going to be more frequent. And I think as an emergency physicians who are at the face of the healthcare system, we're going to be at the forefront. And what really kills me is that I don't see many of our emergency leaders in this spaces. Last week, I was at an infectious disease conference in Atlanta, and great, of course, we need infectious disease to lead this, but we want emergency physicians also to be partners in this. And I know that Sari is working here with the group from the ICU and as such, but I think, when you think of global emergency medicine, that's a hot topic now. Unfortunately, conflict and displacement. Not only, yes, we work there, but we don't want conflicts to happen. But it's going to continue happening, unfortunately. But I think as being trained an emergency physician who can handle an infectious disease, a trauma, and being at a place like NYU Bellevue, you are going to have all the experience to deal with that. And of course, AI, we don't know how that's going to affect our work here for sure. If you know, please teach me. But there's a lot of theories. But of course, when it comes to global health, there are also some opportunities and threats that we see. And, we have to be well versed in that and also implement that as part of the global emergency medicine approach. So for the next 10 minutes, I'm going to talk about 15 minutes, 10 minutes, I guess, so I can give everybody an opportunity. I'm going to go through this because I'm not going to talk about person's story. And the person's story was shared recently, and Celine can resend that article again. One, because it's extremely emotional, and I'm going to start crying if I talk about it here. And Lenny also already had to witness that. But I really want to focus on the science of it and what an incredible response it was. I went to Rwanda to really help with the emergency medicine system strengthening and to help with the residency. I did not plan on being part of an outbreak. And of course, of all the outbreaks, Marburg. For those of you guys who don't know, Marburg is like the cousin of Ebola with the worst mortality. Until last year, the mortality that's been recorded was 90%. So we all thought the ones who were exposed or the one who got it. Thankfully, I didn't get it, but I had higher risk exposure where I had to be isolated from my kids and the entire family. I'm like, I could be isolated from colleagues, it's okay, but the kids is the difficult part. So the first 4 or 5 days, so we had a couple of just individuals that presented with malaria-like symptoms, what you talked about. And I was happy to say when you were talking about the great saves earlier, I'm like, oh, thank God people, it was not Ebola. First, like, I get a call, we have someone with fever, how do we get to test for Ebola? I'm like, have you tested for malaria first, right? So yes, it's very important to be vigilant, but not everybody that comes with fever and joint symptoms are, especially when there's an outbreak somewhere, it is Ebola or a viral hemorrhagic fever. So in the few days before this outbreak was declared, I was actually supposed to come here, go to FACEP and UNGA here, and like there's a nurse that you worked with a few days ago. We thought she had malaria. Within a matter of before what I talked about earlier, the outbreak, the mortality recorded from this country. So this were the countries where the outbreak, Marburg, had happened before. And the recorded mortality was around 80 to 90% everywhere. So this was when it was declared on September 27. And of course, me just do my regular work, preparing to establish a new residency program by October 1st. On September 24, I get this text message on our group from our nurses and doctors, and they say, let's pray for our colleague so-and-so. And I'm like, I worked with her 3 days ago. She was completely fine. And she thought she had malaria, so we tested her. She was negative. She just went home to rest. And all of a sudden, I got a text saying that she was in the ICU. And of course, on the 26th, she died. And this crying emojis meant a lot for that week. Every time somebody sent this, you just hope it's not that colleague that you worked with. And then this was our days between September 24 until exactly a week, because before we knew, a lot of people had died. Before it was actually diagnosed, people fell ill, and then afterwards, when they died, it was already late. So this is just showing, September 26th, we found out she died. 27, it was declared. On the 28th, the emergency department had tests for everybody. And whether you had symptoms or not, you can go get tested. And of course, I'm getting calls from everybody saying, we heard about the outbreak. Why are you not leaving? Why are you not leaving? I feel confident in staying here, including from our Department of Health. We need to prepare Bellevue for you. And I don't think I need to. But I never became ill, thank goodness. So I'll tell you this one last story. So this is in hindsight. We were able to go back and do the investigation by the Ministry of Health and the leadership. So an individual who worked in the mines, a miner, he had some viral-like illness or malaria-like symptoms. He did not go, and like the wife that you were talking about in that presentation earlier, he recovered. But his wife at the time was pregnant, and when she became ill, and she actually delivered while she was ill, and she died. And then, unfortunately, the baby also died. That wife, his wife, had come to our hospital, which is a referral hospital. She spent a week because her symptoms were like HELP syndrome. She was malaria negative. Everybody that she came in contact with, out of everybody, 4 people got sick. Out of the 4, 2 nurses died. Well, 1 nurse died. That nurse that died, she was also pregnant. At the time, they all thought it was malaria. The team of 8 ICU doctors and nurses worked on her for 2 hours as she was coding. Out of the 8, all of them got it, 4 died. This is what's happening within the first week. And this is the paper that was published on New England that just did the contact tracing and traced everybody. And the hospital one cluster is my hospital, and there was an internal joke that there was 2 Americans that brought it here because one was an infectious disease doctor, and that was me. And, I found myself in New York City. It's the epicenter of COVID. I'm like, this epicenter thing needs to stop following me. So, then the ministry has set up an isolation or treatment center. So we pushed many of our patients out. The soonest isolation center was set up within a matter of 24 hours. And the isolation center is like this makeshift hospital that was built for COVID. And it was just too hot. It was too hot. People were working there. By the time they're done for like 5-6 hours, they were just drenched in sweat. And remember, this was the first few days. First, they had high-dose exposure in the ICU. So many people were dying because of the high-dose exposure before we knew it, and we were throwing all the novel medications on them. And it's just, people are feeling so discouraged being in this hospital and dying. So the Ministry of Health heard, like, you know what, we're going to shut down this new private hospital and set it into an isolation unit. It was air-conditioned isolation unit. And there were a lot of reassuring messages that were coming from the ministry and lots of training that I was also a part of. Dr. Tedros came, the Director General of WHO, and he's like, this is the best treatment I've ever seen in the world. And yes, through collaboration, years of investing in healthcare system, the resilient healthcare system, they do have universal health coverage. All the investment that has happened in Rwanda, working towards the healthcare system, has helped defy the death sentence. The case fatality recorded was 23%. And this was the most phenomenal global solidarity. Within a matter of a week, the U.S. had shipped an experimental vaccine, got from Gilead or remdesivir, and also within a matter of few days, we've received monoclonal antibodies from the U.S. Department of State. And this is just me drawn for the very first time administering a known monoclonal antibody to human with my colleague from the Ministry of Health, and the amount of paperwork we had to do for that. And over the, as we got the first few discharges, we were feeling very encouraged. And we got the vaccines in a matter of few days. I never had to administer remdesivir myself during COVID, but this was some of the experimental thing. And I remember getting on the phone with my nurse, the nurses here at NYU at Tisch. I'm like, I have no idea how to do this, and most of my nurses don't. So I was doing this virtually with some of the nurse colleagues here. And we set up a post-exposure prophylaxis clinic with remdesivir, which is a study that we have done. Hopefully, if we have time at the end, I'll talk about it in 2 minutes. And this was just came out of despair. You get up in the morning, you check your temperature. If you have a temperature, you go to the isolation unit. If you don't have a temperature, you go work or you do whatever, in your isolation unit. So it just felt like just depressing and just helpless and hopeless. So we planted the idea, why don't we give remdesivir as a post-exposure? They're like, do you have any evidence? And I was like, I used to give it left or right. I don't know if you guys offered it with VUC as a post-exposure prophylaxis for COVID. I did that when I was at Columbia. And the idea was brought up Monday night. Wednesday morning, we had opened up the clinic. Within a matter of a week, we had administered to 180 people. And that happened, the dosing, you guys know, we have to do a liver function test before and then do 3-day dosing. And then Gilead heard about that, and they reached out, said, we want you to do a retrospective study. So for the next 1 minute, for the study that I'll talk about, it was funded by Gilead. It happened they gave us the funding retrospectively, so they were not involved with the study. And this is my disclosure on that. And just presented this last week at the IDSA, which is the infectious disease conference for all pediatric and adult pediatric infectious disease doctors. So we were able to give that to all the healthcare workers that were exposed. I don't think I have to talk about what remdesivir is to the audience here, but we administered it to all the healthcare workers that were offered, or even needle sticks, we would offer it to them. And we retrospectively went and got, all the data and followed up with everybody who actually took the test. And then we compared it to the other who were offered, but who opted out for the post-exposure prophylaxis. And this were some of the results. You can see that Rwanda has a very young health population since the healthcare worker. Since the genocide, many of the the senior healthcare workers have either, died or have left. So this is the healthcare workforce majority at the main hospitals in the city. And then this was some of the results from, the complications from getting remdesivir. And the two important findings from offering remdesivir as a post-exposure prophylaxis, and this, of course, this has never been done. We also had a lot of opportunity because the outbreak happened in the middle of the city. Usually, Ebola, viral hemorrhagic fevers happens in the middle of nowhere in the rural city, but the fact that it happened in the capital city. And I remember actually calling Dr. Hoffman, we don't know if people are getting elevated liver enzyme. We know that it happens with viral hemorrhagic fever. Also because of remdesivir, do we stop it or not? So I was like, wait, N-acetylcysteine, let's try it. And he sent me a great paper. I was like, thank you, let me float this. So there was a lot of, learning on the spot, and really, of course, our forever attendings who, I'm going to ask you questions even 20 years after I graduate. So at the 10 years, thank you, Bob. He responded, and he sent me this New England Journal article. So we started giving N-acetylcysteine to people. But that is not so this is to say when we gave remdesivir, the liver function tests were not affected, as I showed you in the previous slide, but we were able to increase their incubation period. So it really helped suppress the virus for the people that tested positive after we gave a post-exposure prophylaxis. And the CT value, which is the equivalent of the viral load, didn't show any significant findings, but we also did the seroconversion. So we were able to get CDC, American CDC donated their antibody testing to see actually if it suppressed the virus or not. So we did that. And then you can see, of course, the numbers are very low. We can't conclude anything. This is a hypothesis-generating study. And you can see that for the people who received the remdesivir as a post-exposure prophylaxis, the seroprevalence was lower. So the liver function test, like I said, there was no much difference. But this is the summary of the finding from that There were no deaths reported among the people that received the PEP, the remdesivir as a PEP. The seroprevalence was a little bit higher in the non-PEP group, and the incubation period was much higher and we assume that's because it actually suppressed the virus. So we've told a lot of stories, and the things that we've published on our experience, but of course, I conclude by really recognizing the people that I work with. They're the most resilient human beings. As they were losing their colleagues, they were the ones checking on me because, unfortunately, and for different reasons, some of the foreigners left when the outbreak happened. Whether it's COVID or whether it's Marburg, I hope I don't want to come back to another lecture to talk about another outbreak, but you lose your colleagues, you lose your healthcare workers. And when I worked at Columbia, we also lost a colleague due to suicide, Dr. Lorna Breen. So when I talk about, what we do, we're also, standing on their shoulder and also on their sacrifices. So I just want to acknowledge, and that, most of my talks is in the memory of the colleagues and many others that we lost and that continue to fight. So I'm finished with that. Thank you. So for the minute, if there are any questions, feedback, comments, I'm here. And then I know that Celine has organized a luncheon with the residents, so I'll be more than happy to answer more questions. Working on the residency there, and there's an opportunity for the senior residents and the faculty to come and give a talk either virtually or in person. I've made our lecture days on Thursdays, so it does not interfere with Wednesdays. So there are those opportunities. So the residency program is a 4-year program, and we are now a 2nd year. And the other things that we're working on with the ministry is working on, so I have a volunteer role at the Ministry of Health working on pre-hospital system, and I am not an EMT. I'm not the expert in that, but we are helping with the development of curriculum. And really, Rwanda has been incredible in spearheading many of the emergency medicine, the emergency care system in general. And it's like huge, I just think of it like as a huge lab. And I think, the fact that it's small, it's more organized. If we can actually show and implement, Rwanda will be a show and tell. I've worked in Ethiopia. I've worked in many places, including my home country, Ethiopia. There's so many challenges that happen here and then, especially now, global health financing, all of those things. But Rwanda has prioritized emergency medicine system and emergency care system. Sometimes when I hear the ministers talk, you'll be like, you'll think that me or you or Dr. Manko is like whispering in their ears. The way they talk about emergency care systems passionately, like with such passion, has been so refreshing. So working on a lot of things, we'd love to have you. So, Avi?
Amazing talk. Thank you so much. The spirit of storytelling. I can't not tell one of the first times that we worked together, actually. It was a polydrama. And I think there were 2 level 1s, and we got stuck on one. I think it must have been like Casper's or Whitman told you to put on a chest tube. I was probably crying in a corner or putting an IV, I don't know, either one of those. And you pulled me over and were like, I actually already did a chest tube, and I think you need to do one. And I was like, I don't need to do anything. You just get yours, and we'll figure it out. And you're like, it's really just important for you to learn how to do this as it is for me. And I remember this was intern year. I remember this. You've already done the math, so it's a long time later. That you were so interested in lifting up your co-residents, and I feel that this is so important in how we, look at each other as colleagues, and you really just put into my head how important it is for you to trust your colleagues, and that's kind of how we maintain our education, why we hold our co-residents and residents and students and colleagues to such high standards to maintain both the integrity of our field and the ability to work with such teamwork, and you have taken that little blip that has somehow stayed with me and implemented it on such a large level, and it's just amazing. Thank you so much.
Thank you, Amy. It's about coming home and then somebody will tell an embarrassing story, so that was not too embarrassing, but I appreciate that.
I could do a lot worse.
Yes, but all this to say, that's just not because it's me naturally. It's because I learned it from people here. You know, I owe it to all my, consultants here who are here, like Femia, Lenny, Ina, I see Rana, and I see Hoffman, of course, Dr. Goldfrank, and everybody here that has taught me. I'm not sure if I'm missing anybody. And my co-resident, my underclassman, Aaron Arredondo, I remember about one time, I was like, of course, being female, a black person, there's always that, uncertainty, like the imposter syndrome. And I remember it was Giselle Cruz was coming back as an attending, and I remember, I think this is stroke. And then she was like, if you believe it, it's fine, go ahead. And he was a third year resident, I was the fourth year. And then they won't, so our colleagues, God bless them, sometimes they contradict. It's like, we don't think it's stroke, but we'll go to the CT scan. And I remember Aaron saying, trust your guts all the time. You were right. But, it's just like that camaraderie with an emergency. And it's one of the things that drew me into that, right? The personality. I learned it from people like Salil, Tim, how they looked out for each other, right? So that was not, me just naturally. I appreciate that, but I learned it from others. I learned it from the people that continue to advocate for each other, for the department, and something that I carry with me. So I'm 5 minutes over. I'm really sorry, but I'm around. And if I can please get a picture with all my faculty, teachers. I'm sorry. Of course, if there's a way to do it with the residents too, but I just have to show it to my residents that I went and talked about, in front of my former teachers. So if I can still you guys for 5 more minutes, I really appreciate it. I'm so humbled and honored to be back here. And I just have any emotions. And Amy was about to make me cry, so I'll stop. Okay, bye guys.